This presentation will focus on hernias and will briefly cover the anatomy, the clinical features, and the management, and should take you up to everything you need to know for a finals examination. So the definition of a hernia is the protrusion of a viscus or part of a viscus from outside its normal containing cavity. A hernia can be described as reducible if it can be manipulated back into its original containing cavity, or irreducible if it can't be, either by the patient themselves or by a medical professional. Components of an inguinal hernia include the hernial defect, which are the gaps through which the viscus will project, the hernial sac, which consists of the peritoneum in groin hernias, and this contains the hernial contents. This can be further subdivided into the fundus, the body, and the neck of the hernia. There's lots of different types of hernia, with inguinal hernia being the most common type you'll come across in an exam setting. These are the protrusion of abdominal contents into the inguinal canal, and they're the most common type of hernia in both men and women. However, they're much more common in men than they are in women, with around 92% of the total occurring in them. Femoral hernias are a rarer cause of groin hernia, accounting for about 5% of the total, and these are formed from the protrusion of abdominal contents into the femoral canal. Conversely, these are more common in females than they are in males. There's also many less common types of hernia, which you shouldn't need to know about in too much detail. However, it may be useful to have a list, and these include incisional, umbilical, periumbilical, hiatus, and Spigelian. I'm going to focus on inguinal hernias first of all. It's useful to have some idea of the anatomy of the inguinal canal when discussing these, to have some idea of how they form and what they relate to. The inguinal canal is a pathway from the abdominal cavity into the pelvic cavity, and it begins at the deep inguinal ring, which is located at the midpoint of the inguinal ligament. It can be identified from the surface landmarks of the anterior superior iliac spine and the pubic tubercle, and is located at the midpoint between these. The canal ends and the contents enter the pelvic cavity at the superficial inguinal ring, which is located superior and medial to the pubic tubercle. It's also useful to know something about the components of the inguinal canal, with the components of the canal wall being represented by the acronym 2-MALT. This refers superiorly to it consisting of two muscles, the transverse abdominis muscle and the external oblique, anteriorly by the aponeuroses of the external and the internal oblique muscles, inferiorly by the lacunar ligament and the inguinal ligament, and posteriorly by two T's, the transversalis fascia and the conjoint tendon. You can further divide inguinal hernias into two distinct subtypes, relating to the mechanism by which they form. The indirect inguinal hernias are formed when the hernia protrudes through the deep inguinal ring into the inguinal canal, whereas direct inguinal hernias are formed by protrusion through the posterior wall of the inguinal canal through the transversalis fascia. I'll talk about indirect inguinal hernias first of all. These usually occur in younger patients, typically in either pediatric or young adult populations. They usually form due to the failure of closure and obliteration of the congenital pathway known as the processus vaginalis. This is a pathway which leads from the abdomen into the pelvic cavity and provides the route of descent for the testes during development into the scrotum. The failure of obliteration of this leads to the formation of a patent processus vaginalis. This provides a pathway for abdominal contents to pass into the canal. When fluid passes through a patent processus vaginalis, it can lead to the formation of a pediatric hydrocele. Indirect inguinal hernias are more common and account for about 80% of the total number of inguinal hernias. If the hernia is large or complete, the hernia can protrude through the deep inguinal ring, all the way through the inguinal canal, and through the superficial inguinal ring, and project into the scrotum in men. Hernial bulges into the scrotum will be almost exclusively indirect. Due to the tighter neck of the hernia, they're more likely to become irreducible and either incarcerate or strangulate and present as an emergency. Direct inguinal hernias, on the other hand, protrude through the posterior wall of the inguinal canal through the transversalis fascia, and this occurs in a congenital weak point bound by the anatomical region known as Hasselbalch's triangle. This is formed superior laterally by the inferior epigastric vessels, inferior laterally by the inguinal ligament, and medially by the linea semilunaris of the rectus abdominis muscle. Direct inguinal hernias are less common, accounting for about 20% of the total number of inguinal hernias. They're more likely to be reducible, and this is because the defect and the hernia neck are typically wider. They are less likely to incarcerate or strangulate than indirect inguinal hernias, and are therefore less likely to present as an emergency. They're more common in older adults, and this is due to the chronic processes which predispose to their formation. These are the prolonged effects of raised intra-abdominal pressure and the prolonged weakening of the transversalis fascia. So the main risk factors for the formation of inguinal hernia will be anything which increases the intra-abdominal pressure, and this can include factors such as a chronic cough, and therefore conditions such as COPD or asthma, constipation, long-term peritoneal dialysis, pregnancy, obesity, or ascites. They are also predisposed to by anything which decreases the integrity of the abdominal wall and inguinal canal. This includes connective tissue diseases such as Marfan's and Ehlers-Danlos, acquired defects in the transversalis fascia, laterism, and in the case of indirect inguinal hernias, a patent processus vaginalis. Inguinal hernias will most commonly present via the elective route. A groin mass will be the most common clinical feature and may or may not be reducible by the patient. This will typically be larger on standing and with Valsalva maneuvers, which will increase the intra-abdominal pressure. An important clinical sign will be a cough impulse in which the swelling will expand when asking the patient to cough. Groin pain or discomfort is another common clinical feature which typically gets worse throughout the course of the day. Inguinal hernias can also present as an emergency, and this is a common cause of the acute abdomen. Incarceration occurs where a bowel obstruction forms due to occlusion of the loops of bowel within a tight hernial sac. This occurs when the hernia is irreducible with a tight hernial neck. And this will typically present with the symptoms of bowel obstruction, including nausea, vomiting, and constipation. Inguinal hernias can also strangulate, which will result in bowel ischemia or necrosis due to the torsion of bowel loops and the loss of blood supply. The diagnosis of inguinal hernias is usually made based on the clinical picture from the patient history and examination. Ultrasound and CT can prove useful when this isn't clear. Inguinal hernias can be differentiated from femoral hernias by their relation to the pubic tubercle. Inguinal hernias will always lie superior and medial to this. In addition, it is possible to distinguish direct and indirect hernias by the occlusion test, which relies on the fact that indirect inguinal hernias will protrude through the deep inguinal ring to enter the inguinal canal. First, reduce the hernia and occlude the deep inguinal ring located midway between the anterior superior iliac spine and the pubic tubercle. Next, ask the patient to cough. If the hernia is restrained by the occlusion of the deep inguinal ring, it will be an indirect inguinal hernia. If it is not restrained, it will be a direct inguinal hernia. Intraoperatively, hernias can also be distinguished by their relation to the inferior epigastric vessels. Direct inguinal hernias are located medial to these vessels, whereas indirect are located laterally. There's a long list of differentials for a groin lump, and it is important to differentiate hernias from other causes. This is the purpose of your hernial orifice exam, and the clinical features of a lump from an inguinal hernia can be used to distinguish it from others. For example, most other causes of groin lumps won't have a cough impulse or respond to Valsalva maneuvers. I've included a list of differential diagnoses below and differentiating features from inguinal hernias. In terms of management, small and asymptomatic hernias may require no active intervention and can be observed. Patients, however, should be alerted to the symptoms of incarceration or strangulation and told that if they develop, to seek urgent medical attention. Large or symptomatic hernias that cause patients distress can be repaired via an elective hernioplasty. This involves the placement of mesh and can be performed either openly or laparoscopically. Incarcerated or strangulated hernias require an emergency open repair. They may also require bowel resection if they are unviable sections of bowel. A non-mesh repair is indicated if the bowel is unviable or has unknown viability. I'm now going to talk briefly about femoral hernias. As mentioned previously, these are more common in females than they are in males, and this is because the femoral canal is proportionately wider. Femoral hernias are the herniation of peritoneum and its contents into the femoral canal. The femoral canal lies medial to the femoral vein and artery within the femoral sheath and contains lymphatics in the lymph node of Cloquet. There are a higher risk of strangulation in inguinal hernias, and this is because of the bony and ligamentous limitations that exist on three sides of the canal. They present similarly to inguinal hernias. They most typically have a groin swelling. However, in contrast to inguinal hernias, this will be located inferior and lateral to the pubic tubercle. In addition, the groin swelling should be located medial to the femoral pulse and will be larger on standing or with Valsalva maneuvers. Abdominal pain, nausea and vomiting, and constipation are key signs of an emergency presentation of a femoral hernia. It is important to differentiate femoral hernias from inguinal hernias and other causes of groin lumps. Rates of complications from subsequent strangulation are much higher in femoral hernias. with around 30% presenting directly as an emergency. 50% of these will require subsequent bowel resection due to necrosis. As a consequence of this, the management of femoral hernias differs from inguinal. Femoral hernias as a first-line treatment should have a surgical repair due to the high risk of strangulation. This can be done either laparoscopically or openly. Non-absorbable sutures are used to narrow the canal and prevent recurrence, and a mesh plug is usually placed to reinforce the canal. Open surgery has two main approaches: an infrainguinal approach, which is usually used for elective repairs, and an inguinal approach for emergency repairs. In summary, hernias are a very common cause of groin swellings and can present both as an elective and an emergency admission. It is important to use the findings of a clinical examination to distinguish hernias from other causes of groin swelling. Inguinal hernias are the most common and are more common in men than women. Femoral hernias are rarer and are more common in women than men. The management of a hernia is usually surgical. Thanks for listening. I've included below a few key resources which I used in the development of this presentation.